Coming up on the program, it's back to school time and a season of new beginnings. We'll uncover the powerful lessons of the crucial years by delving into childhood development and then examine how comprehensive stroke certification is giving patients a second chance when every moment matters.
Support for What's Health Got to Do with It is provided in part by the American Brain Foundation invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at americanbrainfoundation.org. Rethreaded knows human trafficking destroys lives, but they also know it's not the end of the story. Rethreaded believes in the potential and power of all survivors to reclaim their lives. Visit rethreaded.com to learn more. And Elevate Med. Through mentorship, leadership development, financial literacy, a robust peer network, and tuition-based scholarship support, Elevate Med is dedicated to the next generation of diverse physician leaders as a tangible step towards the eradication of health disparities. More at elevatemed.org.
From the moment we're born to our last breath, every American embarks on a journey through the intricate maze of the healthcare system. These are their stories, one life at a time. Today we meet Zachary. As Zachary headed back to school, his parents hope for a fresh start. But their once curious 11-year-old now seems tethered to his phone. Hours lost to YouTube, AI friends, and endless scrolling. He's anxious, distracted, and withdrawn. Is this just tween moodiness, or the early signs of tech quietly reshaping his crucial years of emotional development? Hi, I'm Dr. Joe Servin. I'm a practicing neurologist at Mayo Clinic, professor of healthcare administration and policy at Arizona State University. This is What's Health Got to Do with It, which looks at where and how healthcare intersects with your life, helping you get the medical answers you want. Now let's turn our attention back to Zachary. The diagnosis? It's more than moodiness. Experts warn that screens and social media are rewiring younger children's emotional worlds during this pivotal stage of growth. So for this season of new beginnings, nationally acclaimed psychologist Dr. Cheryl Gonzalez-Ziegler joins us to share insights from her forthcoming book, The Crucial Years, The Essential Guide to Mental Health and Modern Puberty in Middle Childhood, ages 6 to 12. And to help families navigate a healthy back-to-school reset for their kids' mental health, we are excited to have Dr. Ziegler join us. She appears weekly on NBC Denver, among many media platforms, as a parenting and mental health expert and an award-winning author who's worked with thousands of families on these very challenges. Dr. Ziegler joins us from Denver now. Welcome to our program.
Oh my gosh. Thank you so much for having me. I'm so excited to talk to you.
We are excited to talk to you. There are lots of questions here, so I'm going to get right into it. Dr. Ziegler, you heard Zachary's story that we started out with. Are we underestimating just how young tech-related emotional challenges are starting?
We are not. I mean, I think that the last year and a half to 2 years with our former Surgeon General really speaking out around the hazards and concerns around screen time, I think we finally have parents' attention. I think we have solid data. And mind you, this is something that really since about 2012, there have been researchers in probably multiple fields, but definitely in the field of psychology, they've been sounding the alarm like this isn't going to be good. These brains are going to get addicted to this. And now we're really talking about the rewiring of the brain. So that's why I am so excited to talk to you of all people about this.
I gotcha. Dr. Ziegler, so many parents think that the real mental health challenges are all about the teenage years. So I'm asking you, what's the most surprising thing you've discovered about what's happening in kids' minds during these so-called easier years that is obviously not the case anymore?
Yes. Oh my gosh. I mean, it's so funny because I've been working with, I usually will say tweens and teens for over 20 years now. And even for me, when I knew we needed to focus on the earlier than teens because there are already a lot of good books out about adolescence. And B, I just feel like if we're talking about problems in the teenage years, we're now behind the ball. Like the ball's already out of the gate, it's rolling down that hill, and we're just trying to like figure out how to slow it down. I felt like I really wanted to focus on the stage right before those teen years. And so when I really looked at, well, okay, what's the formality? Like, what's the stage? It's middle childhood. And middle childhood, just like you said, has been referred to as the forgotten years.
Right.
Freud referred to it as latency. It really was a time where people thought, okay, you're done with 0 to 5 and babies and toddlers. And it's sandwiched in between the teen years that get tons of attention around risk taking and independence. But what happens in the middle? And what I found, even just diving deep into research, is so much happens in this stage that can prevent a lot of the concerns that we have around teens. And that can
Ah.
also help with the modern feeling and experience of what's actually happening, which is two big things, which are earlier puberty and technology and screen time, which never before have we experienced at the rates that we're at right now.
Let me kind of dive into that because you bring up a huge point. My time as a parent, I'm now have grown a son, and so we have a very different era. But as I think as to what will happen when he has children, it seems like it's a completely different world than when I raised him, because now there's social media, now there's climate anxiety, now there's global connectivity. So are we seeing new types of mental health patterns emerge because of these things, or are we just better at recognizing what was already there?
Yeah, I love that you asked me that. And I do, kind of address that early on in the crucial years because I know that people ask me that all the time. Like, is it really this bad? Or is it just that we're better at, diagnosing it or we're talking about it more? And it's a very fair question, but we have been tracking this data even before people were talking about it. And it really is this bad. It really is this much worse. So, two things to highlight that are, probably more than two, but really the depression and anxiety rates that we're seeing, we have been tracking, and they really did get exponentially worse with the introduction of the smartphone. So when we say that, we're really talking about generally like the years 2010 to 2012, we started to see a really different change in the pattern of reported anxiety. And when you say anxiety and depression, what kind of falls underneath that is poor body image and social comparison and poor self-esteem. So what is happening is during the years, right? I think everybody knows that during the teen years, those are like what I would call the identity years. That's when kids are trying to figure out who they are and how they identify. But right before that, these years, this is called, formally it's called industry versus inferiority. So it basically says this is your competence and your confidence. A kid 6 to 12 in these years should be out there playing, trying different sports and different activities, trying, new chores and just things around the house, maybe building, those kinds of things. And they're going to, fail at a lot of things or maybe not have an interest. And then by the time they're 12 and 13, you want to be able to say to a kid, so what are you good at? What do you really like doing? What do you think that you can accomplish?
Sure.
And then you want that child to be able to answer you. And that answer could be anything. It could be, oh, I'm a good soccer player. I'm a good friend. I'm really good at cooking dinner, whatever that might be. And that sets them up for when they become a teenager, you know who you are and what you're good at. And then you're identifying, you find your people. But what's happening now is kids are going through puberty earlier. So they're experiencing this sexual development and changes so much younger, right? From 100 years ago, 5 years younger. They are having an intersection of what we consider adolescence with their middle childhood when they should still just be playing and experimenting, like I just said. And so it's sort of shortening childhood. It's speeding up adolescence. And again, even if it's not within your own child, it's the friends around them as well. And then we have screens that are bombarding them with information that they really, truly can't process. And that's why we are where we are with our mental health crisis.
Got it. I will tell you, Dr. Ziegler, I come from a large Latino Cuban family, and I'm going to ask a question from that frame of reference. As growing up, with lots of kids, a lot of siblings, and my parents always, when we were in that middle age years, they'd always say, "Quit being dramatic." And so my question is, if you sat down with a parent convinced their 8-year-old is just being dramatic or going through a phase, how do you tell the difference between normal childhood up and down versus we need to pay attention to what that person is telling us? It's not just drama.
Oh my gosh, I love that you asked this question. And there were times when my daughter was younger, I'd call her drama mama.
Right.
So I know what you're talking about. And I'm also Cuban. I don't know if we've made that
I
connection.
love that. I love that.
Yes.
So you know what I'm talking about. It's like telenovela in live. Is how it felt.
Yes. Lots of drama is what raised me. That's what I was raised on.
Exactly.
It's such a good question. And so I really, truly want to answer this, I hope, in a way that people go, okay, I get it. So first of all, what is drama, right? We know on the street, you don't need a definition, but drama in my mind would be, your kid, they love to exaggerate things. If they get hurt, it's, they're screaming, crying, or somebody hurt their feelings and they can't get over it and they're going on, or they like to, gossip. And that's, sometimes what we think of as dramatic. Things that are maybe mild to moderate or like really big in their lives. And that can be a temperament, actually, right? So it can be, I want people to hear that. Some kids are born with this sort of temperament and they're just like this. So there's drama as just a personality characteristic, a temperament, or something, a phase they go in and out of. Fine. And then there is truly depression and anxiety. And what is the difference? Okay. So anxiety, when you have anxiety, you're going to see a pattern in your kid where, like, let's just say they're like, your 10-year-old comes home and is like, "Oh my God, nobody sat next to me today. I know it's because I was wearing this stupid shirt and everybody thought it was so dumb." And they're going on, and you're sitting there going, "Oh my gosh." Right. So they're attributing it to, I was wearing this dumb outfit and everybody thought it was so dumb and they didn't want to sit next to me. When you have a kid with anxiety, they're going to, first and foremost, they're probably going to ruminate about it, which means that they're going to be in a circular pattern of thinking and they're not going to be able to stop it. So with drama, you can say to your kid, probably like your mom said to you, "All right, enough. I heard enough about this stupid lunch thing. Like, get over it. Wear something different tomorrow, go to school.
Yep.
It's going to be fine." But with a kid with anxiety, they're going to ruminate, and maybe you're going to start that way and you're going to be like, "Okay, enough. Like, can we move on? Do you have homework? Do you have somewhere to be?" And what you're going to see in them is all of a sudden this sense of it gets generalized. So now they're nervous and they're anxious about all sorts of other things. Like, do you think that other people don't like me? Do you think that anybody's ever going to like, not like this? And you're going to see this, it gets spread out. And so that would be, to me, one red flag. You're also going to see things like they're going to be a disturbance in their sleep. They're not going to maybe even be able to sleep easily. Like, they're not going to go to sleep easily, or they're going to wake up in the middle of the night and they're telling you about it. You're also going to see that they really change their pattern. So they're like, "Oh, well, yeah, I didn't even try to sit with that group of kids because I know that they just really like me." And so now they're going to change their friends, or they're going to change where they go. So a big part of it is, to a parent, I always say this, like, sleep, appetite, mood. Right? If their appetite changes, they're eating more or less. If their sleep changes, they're sleeping more or less. Or if their mood is something that does not come and go, it stays sort of at the steady rate of depression or anxiety. That is a way to differentiate the difference between just drama and maybe a mental health issue.
And to all of our listeners out there, you're listening to What's Health Got to Do with It on WJCT News 89.9. I'm Dr. Joe Servin, and if you're just joining us, we're in conversation with Dr. Gonzalez Ziegler about kids between the ages 6 to 12 years. And we want to hear from you. Tag me on social media at jservin. Dr. Gonzalez, you talk in your chapter on screens a lot about what I think you term parasocial relationships. These are the relationships that these kids have with influencers and AI companions. How are these things reshaping the emotional growth of this age group?
One of the biggest ways that it's shaping it is that they aren't great at talking to people in person. They are not always able to have and hold great conversations. We also see this, what we call this greater sensitivity, where if you're used to, so again, for somebody who this is a new term for, if your kid is on social media enough, right, and they're following multiple or even just a couple people, it doesn't matter. It could be one person, it could be 10 people. It becomes, with big social media influencers, it becomes such an intimate relationship in their mind. Like they are like, I know what their room looks like. I know what they have for breakfast, lunch, and dinner. I know their workouts. I know their favorite color. I know their favorite music. They know all these things, right? That's a one-way street.
Yeah.
And when a kid is growing up and feeling like, and by the way, a lot of times these influencers are years older than them. And I'm even kind of going through this right now with my 12-year-old. Like he watches these influencers that are literally in their mid-20s and they're working out.
Yep.
And he's watching them, right? And he's thinking he's going to look like them. And I'm saying to them, these are grown men. These are men. You are a child. You are 12 years old, right? And so what happens is you start to feel like I can do what they do, or I could be there. They're like my friend. And so then when all of a sudden, zoop, you're now sitting in 6th grade homeroom and you have to go, talk to the kid next to them, you all of a sudden maybe aren't a great conversationalist and you're more sensitive to their feedback. And that's what the research is showing, that kids who are engaged in these relationships get hypersensitive to criticism or constructive criticism or feedback. And so all of a sudden that one-way relationship that they're used to is now 2 ways. Like someone saying like, oh, I don't like that you did that. Or actually, I don't think that's a great idea for our slideshow.
Right.
They're becoming very sensitive and it's really hard to deal with. So it impacts them on multiple levels, from just conversations, friendships, and even their level of sensitivity around them.
So let me get to this question that often I think we debate, even though I have no children at this age at this point. When should you give your kid a phone? What's the right age? What do you say with that phone?
Oh my gosh, this is quite the question, right? Because I think like it's funny, even 2 years ago, I don't know that people were like thinking about it that much, and so there was like, oh, this wait till 8th, which I have in the book, which by the way, I have this whole wait till 8th pledge in the book. And I have had people say to me recently, that doesn't seem late enough. Like that doesn't seem, it needs to be 16. And again, 2-3 years ago, that seemed like unachievable. But here are the things that I do. Instead of necessarily looking at an age, I want parents to actually consider totally other things. And that's what I have in the book, which I am really proud of this chapter because it is created for younger kids. And I think a lot of the guidelines around screen time are really around like older kids. So here's some things to ask yourself. So you want to say to yourself, first of all, why? Why does my kid need a phone, or why do I think that they need a phone? So first thing is truly why. Is it pressure? Is it just because, quote, everybody else has one? Or is there a real reason? So that's the first thing you want to ask yourself. The next thing you want to ask yourself is, how is my kid doing with just literally listening to the rules?
Yeah.
Okay. Because when you introduce a phone, all of a sudden there's a whole bunch of new rules that are annoying for the kid and annoying for the parents to have to keep up with. So you go, okay, I want to get my kid a phone because they're going into 6th grade and, maybe my husband and I are divorced. They have to go back and forth and he does a bunch of things and I want to communicate with him. Okay. So in your mind, that's check. That's why you need it.
Right.
Next question, do they listen to me? And so I want a really solid, yes, by and large, my kids, they're a really good kid. I set boundaries. These are types of things, I tell them to do their homework. They do it. I tell them to not eat the second cookie. They don't. I tell them, I don't like that tone of voice they're using with their sister. They listen. So you really want to assess that piece. And then you want to ask yourself, Am I ready? Am I ready to set parental controls, to put on monitoring device? Think about it. Do you or don't you? I'm not telling you do or don't have to, but you want to think about that. And you as the parent, are you ready to invest the time that it takes to set this phone up, to monitor this phone, to make sure you know how to use it? At that point, a lot of parents say to me, no. So I'll just say, these are some starter questions. There's more in the book to really think about before you make that decision.
Let me ask you, I have to kind of come back to our connection as both Latina. As a first generation Latina mom, how did your personal experiences shape the advice that you're giving us now?
Oh my God. In so many ways, it's so funny. I actually just shared this with an 11-year-old yesterday in a session, some stuff, personal stuff about me. And she was, really, it really did what I wanted it to do, which was it opened up that door. I think she thought, oh, you are relatable. I would say, in the introduction, I write a little bit about my background. I was born to a single teenage mom who had just immigrated from Cuba 5 years earlier. I lived through welfare, food stamps, then became, lower middle class, maybe middle class. I have been through a lot: divorce, step families, assimilation, just assimilating to a country. And I will say that I bring all of that personal experience to the parents that I work with, as well as to the kids that I work with. So even though this book, it's got this subtitle of the essential guide. And I am a fan of your kid is different from my kid. But what I bring to the table is, I get it. There are differences. There are outliers. There are kids who don't get addicted to phones. There are kids who don't talk back to their parents. I understand all of that. But what I bring is hey, but by and large, these are patterns that I see. And so then I can take my years of experience, my own experience in my crucial years, and empathy, and say, let's figure out what you need, you as the parent, and then you as the child, with the information that we have, but without lumping you into some stereotypical category. Because if I had been stereotyped, certainly I think, a lot of what I've accomplished and achieved would not have been written in the stars. That's not what would have been predicted for me. So I'm a big fan of really getting to know kids for who they are and understanding their dreams and what they want. And even for parents, I ask the same question. I wrote the book, Mommy Burnout, and I write in there is what legacy do you want to leave? What type of parent do you want to be? Trying to help drown out the noise. So those are just some ways in which, my own personal and professional experience really, I think, helps me be hopefully really relatable to parents. I have no judgments. And I'm just pro kid, especially at a time right now where people can go online and sort of feel like there's some sort of formula or recipe for, quote, doing it the right way. I think I'm out here to say no. It's actually harder to know somebody as an individual and do it the special way. I think that's why people go to big, broad, general advice, because it's oh, okay, this is what we're supposed to do. So then that's just what I'm going to do. So I think those are some ways.
I got it. So in our final moment, and briefly, and I know this is a rough question, but I want to kind of get it in there. If there's one big takeaway from this book that you hope every parent hears, what's that one message to finish our conversation today?
I would say that these are the years of opportunity. 6 to 12, your kid still thinks you're the most beautiful, smartest, brightest, most amazing human being in their world. And you have the most influence over them, over anything or anyone else. If you wait till adolescence to start having tough conversations, you're now contending with friends and social media and a whole bunch of other things. So I hope people will really look at these as not the forgotten years, but rather the golden age of opportunity years.
I love that advice. Dr. Gonzalez-Ziegler, I just want to thank you so much for the work you're doing, the insights you've given us, and for giving us your time today. This has been fantastic.
Thank you so much, and thank you for your work and for having me.
You bet. We have been talking to Dr. Cheryl Gonzalez-Ziegler. She's a famed psychologist and the author of her latest book, The Crucial Years, The Essential Guide to Mental Health and Modern Puberty in Middle Childhood, ages 6 to 12. Coming up, from helping our children navigate new beginnings in their crucial early years, we'll explore another kind of fresh start that can literally save lives. How our region's newest comprehensive stroke center certification is giving patients a second chance when every minute counts. And we'll be right back. Hey, it's Dr. Joe Servin. I have a new show called This Week in Health, and it's part of WJCT News Now. Local news you can listen to anytime, anywhere. When you sign up, you'll unlock 4 local podcasts delivered straight to your podcast app. I break down the week's biggest health headlines and what they mean for you. Start a free 30-day trial at wjct.org/newsnow. And if you like it, become a monthly donor to support WJCT Public Media.
Hi, I'm David Luckin, executive producer of What's Health Got to Do With It, filling in for Stacey Bennett this week. And these are your weekly health news headlines. Nearly a third of people using OTC birth control had previously used nothing or less effective methods. A new study published in JAMA Network Open finds that about 32% more users of the over-the-counter or OTC birth control pill previously used no contraception, while 41% switched from less effective methods like condoms or emergency contraception. The OTC option, Opill, a progestin-only pill manufactured by Perrigo, has removed prescription barriers, making contraception more accessible, especially for younger people, the uninsured, and those in rural areas. Here's a headline you don't want to be any part of. A case report published in Annals of Internal Medicine highlights a 60-year-old man who was hospitalized after following advice from ChatGPT to eliminate table salt from his diet. When he asked for a chloride substitute, the AI suggested sodium bromide, typically used in industrial settings like pool sanitation. Over a 3-month period, the man ingested sodium bromide, leading to bromism, a rare toxicity now mostly unseen. He developed symptoms including severe thirst, fatigue, insomnia, skin issues, and psychiatric problems such as paranoia and auditory and visual hallucinations. His behavior escalated to the point of attempting to escape the hospital and being placed under psychiatric hold. Doctors attributed the condition to bromide toxicity and emphasized that AI systems like ChatGPT are not substitutes for professional medical advice. Now for some good news. Measles outbreak in Texas is declared officially over. The Texas Department of State Health Services has declared the measles outbreak centered in West Texas, with 762 confirmed cases and 2 child deaths, officially over after 42 days passed with no new cases in affected counties. 42 days represents twice the maximum incubation period, serving as a standard threshold for ending an outbreak. And those are your weekly health headlines.
Welcome back to What's Health Got to Do With It. Just as early life shapes our beginnings, a sudden medical crisis can also be a turning point, a chance for a new chapter when the right team is in place. Up next, we meet Dr. Ravi Pandey, whose work is helping patients face life's most critical moments. But first, let's meet Christina. She is a 52-year-old elementary school teacher in Jacksonville. At lunch with friends, she suddenly drops her glass, struggles to speak, and one side of her face droops. Her friends call 911. At the hospital, a rapid coordinated team swings into action. Minutes later, Christina is receiving advanced treatment few hospitals can provide. What's happening? What's the likely diagnosis? Christina was having a stroke, and every second mattered. And thanks to a highly trained comprehensive stroke team, She got the care that saved her life. Joining us now is Dr. Ravi Pandey. He's medical director at the Florida HCA Memorial Hospital. He is comprehensive stroke director and neurointerventionist, and he's going to talk to us today about what it takes to earn comprehensive stroke certification status and why this matters. Dr. Pandey, welcome to our program.
Well, thank you for having me.
So I understand out of the 5,533 emergency rooms in the United States, you are all now the 297th in the country. That's a small percentage. I wish all of them had it, but that is a huge accomplishment. So when you hear a story like Christina's, a woman suddenly unable to speak or move, her life hanging in the balance, what runs through your mind as someone who's about to help her?
When I listen to Christina's story, I'm really thinking about the timeline of events, where she was when she started experiencing these symptoms, how quickly the EMS responded to the scene and recognized that she was having a stroke, how far she was from a certified stroke center like ours. Your listeners may have heard of the phrase, time is brain. That's because every minute after the onset of stroke symptoms, you're losing about 2 million neurons.
Wow.
So my mind really races through her timeline.
So tell us when you're saying that, and I get what you're saying, time is brain here. How does having a certified comprehensive stroke team change what happens for her? I mean, what does it mean?
Yeah, so a comprehensive stroke center is better prepared than any other hospital to care for patients like Christina, especially during those first crucial minutes after she arrives to the emergency department. In the stroke world, we have this thing called golden hour, which is the first 60 minutes after a patient arrives to your emergency room. What we mean by that is if we give Christina this clot-busting medicine or start the stroke surgery within that first hour of her arrival to our emergency room, we give her the best chance at recovery. So at a comprehensive stroke center, even before Christina arrives, our team is working in unison to achieve that goal of giving her that IV drug within the first 30 minutes of her arrival or getting her on that thrombectomy table to start the procedure within the first 60 minutes. So this orchestrated response is what changes a potentially devastating outcome into a chance for significant recovery.
Our listeners out there are going to wonder, okay, you've just given us the description of a comprehensive stroke certification. Why should they care? Why does this matter versus someone who is not?
So what it means to get to a comprehensive stroke center for your patients is they're going to have the highest level of stroke expertise and technology available to them 24/7. It just goes beyond the initial stabilization and just giving them clot-busting medicines. The comprehensive stroke center will cover all aspects of patients' care, not just the diagnosis and the treatment early on in the emergency room, but also the therapy, rehab, the discharge planning. All of that is done in a very coordinated fashion in a comprehensive stroke centers. So we have to have a state-of-the-art imaging technology, such as CT perfusion, which identifies exactly the amount of tissues which is at risk from the stroke.
Okay.
We have these AI softwares that automatically read the CT angiograms and perfusion studies, and they spit out text messages to our team members that someone's having a large vessel occlusion to get ready for thrombectomy procedure. You'll have access to neurointerventionalists like myself who can perform mechanical thrombectomies or...
Explain that. So I want to help our listeners out. Tell us a couple, just kind of define the terms. What is a thrombectomy? In as simple terms as you can.
Yeah, so mechanical thrombectomy is basically a procedure where we minimally invasively go through either groin or wrist of the patient with a small catheter and feed that catheter and wire all the way into the brain where that clot is lodged. So if you
Okay.
have a clot lodged in a major blood vessel in the brain, and you're having lack of flow to that area of the brain, we'll go physically to that clot with the catheter and either aspirate the clot or
Aspirate means like pull it out.
Yeah, pull it out either by just suctioning it out, or
Okay.
we'll use a device like a stent retriever to just pull out the clot with that. And that's done very minimally invasively, small little incision in the groin or through the
Okay.
wrist. So that's mechanical thrombectomy. That's something that we can provide to a stroke patient in our comprehensive stroke center.
You also mentioned a couple other terms, so I'm going to ask for those definitions. CT angiography, what does that mean?
CT angiography and CT perfusion are these advanced CT scans that
These are like CAT scans.
CAT scans,
Uh-huh.
yeah, that look at the blood flow in the brain.
Okay.
So as the blood is passing through the blood vessels in the brain, it'll follow that path of the blood flow and it'll detect where the clot is lodged. So if it's lodged in the middle cerebral artery or anterior cerebral artery or basilar artery, we're able to see those on the CT angiogram. And perfusion study just tells us how much perfusion is going still to the brain and that tissue, and how much is already died off. That means if the patient arrives to our hospital 24 hours later, there may be a lot of damage already done to the brain. So we're able to see that on the perfusion study. So that's a CT perfusion.
Got it. I think I got my terms down there. I just want to make sure everyone understood what we were kind of talking from there.
So also at the Comprehensive Stroke Center, you're going to have 24/7, 365 neurosurgery coverage. So if you're having hemorrhagic stroke,
Which means bleeding.
bleeding
Uh-huh.
in the brain, you can go and evacuate that hematoma or do a craniectomy, remove a piece of skull to help with the swelling, or drain placement to monitor intracranial pressure. We're going to have dedicated neurocritical care docs and
So that's intensive care.
intensivists that are going to watch you after you've gone through all these procedures and kind of monitor very closely. We have a team of neurocritical nurses, nurse practitioners that watch you as well. And not just this, but also after the acute first few days of treatment, we have a continuum of care. So we have rehab specialists
Okay.
and physical therapists, speech therapists that are going to work with you and optimize every phase of your recovery.
I love that. I know that someone like you are the leader. You're out there. You in some cases are pulling the clot out or working with others that are doing that as well. Talk about the unsung team members that make that difference in stroke care. Besides the neurologists, neurosurgeons, things of that sort. Who are those folks that really make a difference?
Right, that's a great question. So there are so many, and their contributions are absolutely vital. Beyond the physicians, nurses, and the therapists who are often in the spotlight, we rely very heavily on essentially all our team members, stakeholders here, such as the EMS or the paramedics. These are the true first responders. They arrive at the scene when you call 911, and they recognize the stroke symptoms and initiate care even before person reaches the hospital. They will at times initiate a pre-alert and let us know that the patient is coming in, so we are ready for the patient. Then we have the CT and the MRI technologists. They prepare the rooms for the stroke patient even before they come.
Wow.
We have IR technicians and IR nurses who help me remove that clot.
And IR means these
Interventional radiology
Okay,
technicians. And then we have anesthesiologists that will watch the patient while we are doing the procedures. So their blood pressure is monitored, and if they have any cardiac events, they're kind of watching those. Then we have pharmacists who are ready to go when the patient arrives with blood pressure medicine, with TPAs or TNKs or clot-busting medicines. Then we have caseworkers, social workers who will help you navigate the post-stroke journey, so to speak, arranging rehabs and follow up with primary care doctors, etc. And finally, even the environmental services, they help us keep the OR clean and IR suites clean and sterile, and turn the patient's rooms so we can keep moving.
I love hearing it really does take this huge village of people to kind of do this. And that is a huge resource ask for the hospital, the institution, and to put them all together. It's incredible around the patient. One of the things that I'm kind of curious is that you mentioned physical medicine and rehab. You know, how has stroke care expanded beyond emergency treatment into the other sides of this, preventing this from happening to begin with, or the other side, the rehab side? Talk about that piece of the equation.
Yeah, so stroke care has truly evolved into a full spectrum of care. While emergency treatment kind of remains the paramount for acute events, we have significantly expanded our focus on prevention and rehab. So this means aggressive management of the risk factors such as diabetes, high blood pressure, high cholesterol, atrial fibrillation. We educate patients on lifestyle changes and medical therapies to just prevent the stroke from ever happening.
Okay.
And if it does happen, then we work with the patients to prevent future strokes from happening. So that's the secondary prevention strategy. Same thing with rehab. We have very early rehab goals for our patients. We initiate physical, occupational, and speech therapy within the first 24 hours of patient's arrival to the emergency room.
Okay, got it.
So we do early mobilization and very intensive specialized rehab for patients, individualized treatment plans, and just even follow up on these patients to get them to do outpatient rehabs. So it's not just about the acute care anymore. It's about rebuilding their lives going forward, even after discharge.
I love the holistic approach. And to all of our listeners out there, you're listening to What's Health Got to Do with It on WJCT News 89.9. I'm Dr. Joe Servin, and if you're just joining us, we are talking about the importance of comprehensive stroke certification. And we want to hear from you. Tag me on social media at jservin. Dr. Pandey, you brought up one of the things that hit me as I'm listening to your description is that there's a lot of technology. I mean, I heard tons of it. And I'm just wondering, how has something like AI that we talk about on this show all the time now, or robotics, which we don't talk about all the time on the show, changed? What happens to patients, the outcomes, if you will?
Yeah. So these technological advancements have been really transformational in stroke care. We were talking about AI recently all over news, but we've been using AI in stroke for over a decade now.
Oh wow! So
we've had a app called Rapid AI or Viz AI. I'm sure you've heard of those apps. Yep. I don't know if your listeners have ever heard of AI in medicine, but what we are able to do is on our phones we are able to view patients' images really quickly, and we don't even have to wait for the radiologist to read the CT angiograms and perfusion studies. The AI software has been learning for over a decade all these CAT scans and CT angiograms and perfusion studies, and it automatically detects a large vessel occlusion. We call that ELVO, LVO.
Wow.
And it will give out alerts. So if you're not close to your phone or looking at your phone, you will even get a very specific alarm is set on your phone. So you get an alarm when you're on call that there's a patient with a large vessel occlusion.
Oh my goodness!
So your attention is quickly drawn to your phone. You look at your phone, and you're on call. You got to go in and take care of this patient right away. So it saves us time from the radiologist having to read the test and then reach out to you. And it may take another 10 minutes for the radiologist to find who's on call, talk to them. So this has cut the time significantly. The other thing is telestroke. Again, we've been using telestroke technology, telemedicine in stroke care for about 15 to 20 years now.
That's amazing. Way before COVID.
Yeah, way before COVID. And it's been a game changer, especially in rural areas or underserved areas or freestanding emergency rooms. You can now talk to the neurologist on the video conferencing machine, the tele machine, and they're able to review the images on the Viz app or one of those AI apps, or just on the screen, and even guide the local medical team to the acute treatment. And then sometimes they will even follow the patient to the comprehensive stroke center. So if there is a large vessel occlusion, the patient will be shipped to our center.
Right.
And the same teleneurologist who saw the patient in Georgia,
Right.
small rural hospital, will log in again and follow up and give us the handoff, letting us know that he or she saw the patient and had provided this care in Georgia. So it's amazing.
It
And
is.
speaking of robotics, I'm sure your listeners have seen these social media videos of a robot stroke glove, which is this robotic glove that helps with mobility and dexterity with your hand that's suffered stroke and is weak. So these robotic devices are now helping stroke patients rehab, even at their homes, or provide high-intensity rehabs to patients that the physical therapist is not always available to provide for long durations of time. And the future is really going to be, and I can't wait for this, is in my field, the neurointerventional field, we have robots that are being built to perform interventional procedures remotely.
Amazing.
Or from a control room outside, so we're not getting exposed to the radiation as much.
I love this. Let me kind of put it on the human side. You talked about on call. You talk about you're on emergency. It's you. It's up front. It's 3 a.m. Your phone rings, as you talked about. What's the kind of case that still makes your heart race, even with all these cool advances? Talk about that piece.
So as a neurointerventionalist, calls that get my heart racing at 3 a.m. are really the ones regarding young stroke patients that are having a devastating stroke.
Sure.
It's because of the profound impact this can have on their entire life ahead. These are often healthy individuals who don't really have a lot of underlying known health conditions. They may have history of atrial fibrillation or some genetic disorder or fibromuscular dysplasia.
So these are conditions affecting the blood vessel or a funny heart rhythm like an atrial fibrillation. Okay.
Right. That may cause them to
Sure.
have a stroke, and sometimes they don't, they are not aware of these conditions, and they will end up in our emergency room with major strokes from a large vessel occlusion. They're paralyzed on one side of their body and can't speak. And unable to communicate. And so being able to help them and help them regain strength and live independently again, that truly motivates me and gets me going, even in the middle of the night.
On that point, what's the most surprising or maybe memorable lessons you've learned from all these experiences and treating all these stroke patients? What do you take home from it in terms of lessons?
Yeah. One thing that always surprises me is the resilience of people. I've seen patients who have experienced devastating strokes or bleeding in the brain and were told that they will never walk again. And, sure enough, 6 months later, a year later, I'll follow up with them in the clinic, and they're living independently, working full-time jobs, and they tell me that they've just danced at their daughter's wedding. So it reminds me that recovery isn't just about medicine. It's about hope, determination, and human spirit. It's not something you can, you're taught in textbooks.
Let me ask, in our final moments, in it's 2025. Let's say we're talking 2035. Although sometimes I'm always nervous to point out anything like that. But in 2035, what do you hope stroke care looks like here in Florida or beyond, for that matter?
In Florida, we're making big advancements in these in stroke care, especially comprehensive stroke centers are being certified throughout the state, but still about 20% of Floridians do not have access to comprehensive stroke
Wow.
center within 60-minute drive from their homes.
Which is essential for that golden hour,
Exactly.
preserving the brain.
Exactly. And these are mostly in the central Florida. So I'm hoping to have, just these hyper-specialized telestroke networks that can help even through mobile stroke units be able to provide care at patients' doorstep. Jacksonville already has a mobile stroke unit now. So these stroke units would be capable of sending a teleneurologist right at your door.
Wow.
And they even have a CAT scan inside of them. So you can get a CAT scan, you can talk to a teleneurologist outside of your doorstep. So hopefully these advancements will be there in 10 years. We'll have more access to care, reduce disparities in care. So we can close the gap in stroke outcomes for all communities, ensuring that every Floridian has equal chance at recovery from these life-threatening stroke events.
I love it. Dr. Pandey, I want to thank you for the work you're doing and for giving us your time. You're a busy guy to be coming here and talking to us in studio. Congratulations again on HCA Florida Memorial's Comprehensive Stroke Certification designation. I'm delighted for you guys and for all the people it'll help.
Well, thank you for having me. Thank you, Servin.
It has been wonderful. We've been talking to Dr. Ravi Pandey. He is neurointerventionalist, director of the Comprehensive Stroke Certification Program at HCA Florida Memorial Hospital here in Jacksonville, and they recently became the 297th hospital in the country to receive that designation. Well, that's our program for today. We hope you've enjoyed our show. If you missed anything, you can listen to the full episode at WJCT.org and on your favorite podcast app. Thanks to all of our guests. Our executive producer is David Luckin. Stacey Bennett is our producer. Brady Quorum is our director. Caden Collins is our researcher. If you have questions about this or any topic, let us know by calling us at 904-358-6362, email us at health@wjct.org, or tag me on social media at jservin. I'm Dr. Joe Servin, and you're listening to What's Health Got to Do with It on WJCT News 89.9 Jacksonville. Thank you for listening, and stay in touch.
Support for What's Health Got to Do with It is provided in part by the American Brain Foundation invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at AmericanBrainFoundation.org.
Rethreaded needs you to make a difference in the lives of human trafficking survivors. Learn more about supportive services and an array of survivor-made products at rethreaded.com.
And by Neurelis, a leading neuroscience company focused on the development and commercialization of therapeutics for the treatment of epilepsy and other neurologic disorders. The company's unique drug portfolios strive to address unmet needs in patient care. Learn more at Neurelis.com.